Good afternoon, everybody, and welcome to this important webinar, Ministries, Association Health Plans, and Short-Term Plans. What is a state to do? These are challenging times, particularly in the individual market, and we're really pleased to have this important webinar and timely webinar with our great colleagues at Georgetown. This is Trish Riley from the National Academy for State Health Policy. Let me just quickly go over some housekeeping details. Please, there are many people on this phone, so we ask you please to put the phone on mute. Do not put it on hold because we've had the experience of being able to listen to people's music during hold, so that's not exactly great. So please put it on mute. There will be an opportunity we're going to break up the presentations with questions. There'll be an opportunity to ask questions. You'll see a chat box on your screen. Simply type in your question and we will get to them in the order in which they are submitted. We will, at the conclusion of this webinar, you'll see an evaluation. We very much would appreciate taking 1 minute at the end of the webinar to fill that out. It always helps us improve the work we do for you. And the slides will be posted. The webinar will be available for people who wish to see it later on. We particularly want to thank the Robert Wood Johnson Foundation for their support that's made this afternoon possible for us. We are really delighted at the National Academy for State Health Policy to be able to collaborate with Georgetown Center on Health Insurance Reforms. If you don't know the center, it is an extraordinarily important resource for the work we all do about health insurance. They have a team of experts on private health insurance, health reform. They conduct timely and extremely helpful research and policy analysis, provide technical assistance to federal and, importantly, state policymakers, regulators, and advocates. They're based at Georgetown University's McCourt School of Public Policy, and you have a link there to get more information. If you're not familiar with their work, it's an extraordinary resource for all state officials. We're especially pleased to have all three of the folks we've been working with so closely with us today to make presentations and respond to your questions. Let me introduce them in the order in which they'll speak. Kevin Lucia is the Senior Research Professor at the Center on Health Insurance Reforms. All the folks are from the CHIR, the Center for Health Insurance Reforms at Georgetown. He's the Director of Georgetown University's Health Policy Institute. He conducts extensive legal analysis on states and on how the states and the federal government regulate, focus on access, affordability, and adequacy of coverage. Kevin's been a real resource, and he previously served on the board of the D.C. Health Exchange. He'll be followed by Danya Palanker, who's an assistant research professor at the center at Georgetown within the Health Policy Institute. She analyzes state and federal health insurance market reform, including the implementation of the ACA, with a particular emphasis on insurance benefit design, access to health care, and coverage for chronic health conditions. Last but most certainly not least, Joanne Volk, the Senior Research Professor at the Center. She is known for her research, has authored many papers. She provides lots of technical assistance on state and federal regulation and legislation about private health insurance, including lots of work that we particularly appreciate with health insurance marketplaces under the Affordable Care Act. With that short introduction of these great panelists, let me turn now to Kevin to frame up our discussion today and move us into the meat of the meeting. Kevin.
Great, thanks, Trish. Thanks for that nice introduction. And as far as in way background, in October of 2017, President Trump issued an executive order directing federal agencies to work on new public policies that would expand access to alternatives to ACA-compliant coverage. In general, alternative coverage arrangements sit outside the individual market risk pool and do not have to meet many or sometimes any of the federal consumer protections that otherwise apply to individual health insurance. While these arrangements may be appealing to some healthy consumers, particularly those because of their generally low upfront costs, they are typically far less protected than coverage compliant with the ACA, and therefore less attractive and less accessible to individuals who believe that they will need medical care. These coverage products have the potential to siphon off healthy individuals who otherwise would likely have obtained insurance in the ACA individual market, As a result, they contribute to smaller and relatively sicker risk pools in that market with higher potentially premiums and fewer plan options for consumers who remain. Although states have broad authority and ability to regulate these coverage arrangements, some do and some don't, and others are evolving. Next slide. As mentioned, much of the focus today will be on short-term plans and AHPs, as the Department of Labor is poised, or the federal agencies are poised to release final regulations that encourage increased availability of these coverage options. In addition, healthcare sharing ministries are expanding quite quickly in a number of states, especially where consumers are facing steep premium increases for comprehensive individual market coverage. Please note that there are many more non-ACA compliant arrangements out there, such as direct primary care arrangements, discount cards, hospital indemnity products. In the coming months and years, state policymakers will be faced with the extremely difficult task of determining how best to regulate these types of non-ACA compliant arrangements as they try to balance affordability, adequacy, and the stability of the individual market. With that, let me turn it over to Micah to share thoughts on the regulation of short-term plans.
Thank you, Kevin. I want to start by talking about what short-term plans are, including what they do and don't cover, before moving on to how they are regulated, the proposed federal changes, and how states can and are responding. Short-term plans have historically been designed to fill temporary gaps in coverage, such as before coverage starts in a new job or between ending school and starting a new job. People in these situations now are usually eligible for a special enrollment or to stay on a parent's plan. According to one carrier I spoke with, the average length of time a consumer is enrolled in a short-term plan is just over 4 months. And as you can imagine from their name, they are not designed as an alternative or replacement to long-term coverage, but it is expected that there will become an alternative to long-term coverage when the federal regulations are changed. And before the ACA, a large role short-term plans played was providing creditable coverage for people who would otherwise have a gap that would result in pre-existing conditions being excluded up to 12 months when they started a new group health plan. This is no longer an issue since pre-existing condition exclusions are now banned. And short-term plans are not considered individual health insurance under federal law, although some states do consider them to be a type of major medical individual plan. They are in a separate risk pool from the ACA-compliant market, which means if an issuer is selling short-term and ACA-compliant plans, they're segmenting their risk market between the two types of plans. And short-term plans are exempt from all of the ACA standards, bans on pre-existing conditions, coverage of essential health benefits, medical loss ratio, rating protections, cost-sharing protections, and more. But states can, and some do, apply some of these standards to the short-term market. Next slide. So what do short-term plans look like? To begin, they do exclude many services and conditions that are covered by ACA-compliant plans. Pre-existing conditions are almost always excluded. There is one issuer starting to sell plans in some states with limited pre-existing condition coverage, up to $12,000 for some conditions such as asthma, but at an additional cost. And a recent study by Kaiser Family Foundation looked at 4 essential health benefits, found maternity was excluded by all plans, although short-term plans do often cover complications related to pregnancies that might cover some complications related to something such as preeclampsia, but those services are then usually excluded if the woman was pregnant the day the contract started. And well over a majority exclude prescription drugs and substance use treatment, and over 40% exclude mental health services. And then plans also have a variety of various types of condition-specific or service-specific exclusions. These are some examples on the slide. You'll note one excludes hospital emergency due to illness unless confined. That would exclude something such as an emergency visit for asthma or other respiratory distress if it was managed in the ER without the individual becoming inpatient. And just noting, some plans also exclude some high-risk activities. The ones that I've seen are horseback riding, rock climbing, and interscholastic sports, and sometimes include activities to prepare for the high-risk activities. And short-term plans do cover many services generally covered by insurance, such as physician visits, diagnostic testing, and hospitalization. And on the next slide, I'm going to talk some about the cost sharing of plans. These plans generally do have dollar value limits, and generally they're between $250,000 to $2 million, and for some it's per contract period, other times per lifetime. I've seen as low as $100,000, but that was on a plan that was guaranteed issue, so it covered people with pre-existing conditions. Not all insurers, but some use internal limits, such as what's listed on this slide. And there was one case highlighted in comments to the proposed rule of a person who was enrolled in a plan with similar limits that had only $12,000 paid on the $200,000 bill for heart surgery, particularly because of the $2,500 limit on surgeon and anesthesiologist fees and $10 per night limit in the hospital. And one thing that is really an unknown in this market is what type of limits might exist that aren't in the brochures, particularly such as what the insurers consider to be reasonable and customary. Some do use networks, but others allow you to go to any provider, and then it's not clear what they would actually reimburse compared to what's billing and what would be balance billed. Cost sharing generally looks like most insurance, deductibles, copays, some co-insurance, and out-of-pocket maximums. And there's usually a variety to choose from very low deductibles with higher premiums to lower rates and higher deductibles. But something to keep in mind is that sometimes the deductibles do not count towards the out-of-pocket maximum. So a $5,000 deductible, $10,000 out-of-pocket maximum is actually a $15,000 out-of-pocket maximum. And another thing that's different from most individual and group insurance is that family members of 3 or more may find that the individual deductible is 3 times the individual deductible, not 2 times. And on the next slide, talk a little bit about underwriting. These plans, most short-term plans do only cover people who pass an initial underwriting. This is an example of the type of questionnaire from eHealth. They are generally shorter than a lot of the questionnaires for individual market pre-ACA. But a couple things to note is this one does exclude people who are expecting a child, whether through pregnant, an expectant father, or in the process of adoption. And then the other piece is that a lot of these issuers do use post-claims underwriting. So you may answer no to all of these, but then they decide that you actually did have signs or symptoms of a condition and rescind retroactively. So now on the next slide, I'll get into some of the regulation. As you likely know, in 2016, the Obama administration changed federal regulations to define these plans to duration under 3 months with no extension or renewals. And this faced concerns that people were using short-term as primary coverage and that it was causing adverse selection away from the ACA-compliant market. And short-term plans have never satisfied the individual market. But recent proposed regulations would revert to the prior definition, allowing plans offered again up to 12 months and allowing extensions with the approval of the issuer. And it's, I think, one of the unknowns that was asked in the short-term proposed rule was whether they will find a way to allow easier renewal beyond that 12-month period. And both the current rule and the proposed rule do have a notice requirement about some of the limitations of these plans. The next slide, I talk about state regulation. Most short-term regulation is left to the states. Some states do limit duration to less than 12 months. It's usually a 6-month limit if they do. However, Oregon and very recently Maryland and Vermont now limit to 3 months. Often some of the states that limit to 6 months do allow plans to be offered longer, but basically there's a lot of individual market requirements that apply if they are offered more than 6 months, so it really effectively limits the plans to 6 months. And most of the state limits do not prevent issuance of a new policy at the end of the contract. 10 states apply all state benefit mandates, but no states require the full essential health benefits. And applying a state benefit mandate does not make the service covered if it is a pre-existing condition, but it may if its entire category is excluded. So, for example, California now requires the contraceptive mandate to apply, and that would apply even to insurers that do not cover prescription drugs. And 3 states, Massachusetts, New Jersey, and New York, effectively banned short-term plans because they apply all requirements to the individual market to all plans offered in the individual market. And this was really part of the 1990s reform that they had in those states, and there's really just not room for short-term plans in their code anymore. So next slide, I want to start talking about options for states. States have a lot of options if they are looking to protect their market from segmentation as these plans are expanded. The first thing, and that most states are looking at, is limiting the contract duration, as Maryland and Vermont recently did, and a number of other states, including Hawaii and Illinois and the District of Columbia, are considering. But limiting contract alone does not prevent insurers from doing what's called stacking plans, which is selling multiple plans at once with staggered start dates. So basically, someone ends up covered for an entire 12 months because they buy 4 plans at once. There are some ways to stop this or to try to limit this. Oregon's law that was passed after the 3-month limit in federal regulations defines renewals to include issuance of a new policy within 6 months of the end of a contract. So one insurer cannot sell you plans that just are consecutive. Illinois is considering a bill that would limit duration to 6 months and prohibit any insurer from covering an individual for more than 6 months within a year. So basically, one issuer couldn't cover you for an entire 12 months. And Colorado has a law that doesn't allow an insurer basically to cover you with does not allow an insurer to cover any individual that has already had 2 short-term plans in a 12-month period. So you really then could not be covered, for example, 18 months straight. You could be covered 12 months straight, but not 18 months straight in Colorado. And similar laws could be used with shorter duration to try to keep people covered to, say, 6 months. And Maryland also recently prohibited plans from applying different underwriting standards depending on whether a person is enrolled in a short-term plan. What this effectively does is stop a plan from saying those already enrolled don't have to go through underwriting again. They'll automatically be given a new plan, and therefore finding a way to just easily have somebody enrolled in 4 short-term plans throughout the year. It just basically treats everyone the same. On the next slide, I start by talking about some ways to level the playing field. And states can do this basically in order in order to bring plans more into compliance with some or all individual market rules. There is likely a tipping point and some market rules that will keep issuers out of the market. I don't know if that's fully known really at this point. We do know in Rhode Island where they have numerous protections, including a medical loss requirement and pre-existing condition protections, no short-term plans are sold. However, Rhode Island is also a very small market, which would affect that. Some of the other examples, though, of what could be done is the bill in Illinois would limit rescissions to instances of fraud similar to the ACA, and states can apply more benefit mandates and appeals protections, as well as otherwise improving consumer protections. And states can also take efforts to reduce the risk of market segmentation by, including short-term issuers in any assessments for a reinsurance fund, applying a medical loss ratio, limiting the rating factors similar to the ACA so that it isn't price-wise so much more attractive to young and healthy. And also Hawaii had an interesting piece in their bill that's at the governor's desk that would prohibit sale to anybody who is eligible for coverage through the marketplace the prior year. And there are other options that are not quite as extreme as that could, for example, limit to somebody who is currently eligible to enroll through an open or special enrollment. And on my next slide, I'll end by just going over a few more things that regulators can use their own authority to improve transparency and oversight. There is not really good data on enrollment in these plans, and requiring reporting by insurers of enrollment could help better understand the market, as well as conducting a regulatory review. When California started to look at some plans in this market, they did find some were not complying with state law, and when they were informed, the plans decided to drop, and the insurers decided to drop out of the market instead of complying. And also requiring stronger consumer disclosures. And just to note, there are also some things I didn't talk about in as much detail, but California is considering legislation that would ban short-term plans entirely, and Washington State is currently using their regulatory authority to propose regulations around short-term plans. We don't know exactly what it will be, but there is an expectation it will limit plan duration, among other things. So thank you so much, and I will return to Trish before we move on to association health plans.
Okay, thank you, Dania. A lot of material. We had a question. Don't insurance fundamentals generally require pricing based on risk in order to avoid adverse selection?
So I mean, that is part of how insurers price. I think when I'm talking about adverse selection in this market, it's adverse selection between away from the ACA compliant individual market. So because there's such limited rating factors in the ACA compliant market, and they're very comprehensive coverage requirements, for someone who does not have a subsidy and is looking at that full premium for the ACA compliant plans, if they are healthy and they get a very low price on that short-term plan, they may choose the risk of having the lower coverage in the short-term plan. That causes adverse selection away from the exchanges. In the same way, someone in that similar position who has a lot of health needs may find the way to pay the higher premium and therefore adversely select into the ACA compliant plan because they know they need that. So the adverse selection is really not about the short-term plan itself. It's sort of having some plans that are able to freight that way and design their benefits differently in comparison to a market that's limited in how it can rate and limited in or required to offer a higher level of benefits.
Okay. And one other quick one before we move on. Is there any evidence to demonstrate that limiting short-term plans to 3 or 6 months results in increased take-up in the ACA markets, or does it just push people into ministries and uninsured?
That's a good question. There really has not been a lot of research into what happened, and honestly, it was a very short period that we actually had the 3-month limit because it didn't come into effect until April of 2017. So there actually were, for in early 2017, plans still being sold for 12 months. So there isn't a lot of specific evidence. I will also note, as I said, there were some issuers and some online brokers that were stacking plans, so people were still buying 12 months of coverage even after April through that process if they were being directed or finding somebody who was selling in that way.
Okay, great. Let us move on. Thank you so much, and we will circle back at the end of the webinar for additional questions. So, Kevin, back to Kevin Lucio.
Okay, thank you. So before the ACA, millions of individuals and small employers bought health insurance through associations called AHPs. Associations such as professional or trade associations were often created to further common economic interests. Some states recognize AHPs as a separate insurance market or part of the state's large group market and regulated AHPs under regulatory standards distinct from other health insurance in the individual and small group market. Sometimes the standards that applied to AHPs are different than the standards that applied to these markets, such as in the area of underwriting, rate restrictions, portability protections, benefit mandates, and rate review and form review requirements. And often it was these regulatory differences that served as powerful incentives for issuers to sell AHP coverage. And they led to some pretty sizable AHP markets in some states. There was an NAIC survey in 2011, and state regulators in Wisconsin estimated about 30% of the insurance in the individuals market was sold through associations. In Ohio, the survey suggested approximately 72% of the individual market coverage was written via association business. Under current federal law, including the ACA, association coverage does not exist as a distinct category of health insurance. The general rule is that health insurance policies sold through an association to individuals are regulated under the same federal standards that apply to the individual market, and small group market too. Following the implementation of this kind of look-through approach to AHPs, under the ACA, insurer interest in marketing health insurance to individuals through associations largely fell off in most states. In states like Vermont, which had a pretty significant AHP market prior to the ACA, this federal interpretation coupled with state action shifted AHPs coverage sold through AHPs into the ACA-compliant individual and small group market, resulting in greater stability for that market, for the insured market, the marketplace. One important but limited exception applied when an association met a federal standard for being a bona fide group or association of employers under ERISA, and its health insurance coverage, when it met this kind of steep standard, was treated as a single employer group under ERISA. And federal guidance states that this occurred in very rare instances where the association of employers was deemed to be a single employer sponsored under a single group health plan. And next slide. Under the proposed federal framework from the Trump administration, it would be basically really easy to form an AHP. So no longer would it happen in the rare instance. It would be pretty easy to form, then offer somewhat cheap coverage because it wouldn't have to meet the same standards, and then expand the AHP nationally. So associations of employers or self-employed individuals would be allowed to form an AHP for the sole purpose of offering health insurance, form an AHP without a common interest other than shared industry or shared location. For shared industry, kind of think National Association of Carpenters. So you citist in one, you set up the association in one state, and then you sell nationally to carpenters in other states. Or maybe a shared location, think a Chamber of Commerce. And then they would also be able to offer health insurance that qualifies as large group coverage to all of its employer members, regardless of their size, and including self-employed individuals and sole proprietors, referred to in the proposed reg as working owners. We can move on to the next slide. It would also offer health insurance that does not have to comply with many of the ACA's consumer protections. A big one would be essential health benefits. The individual market and small group market have to meet essential health benefits and rating protections, and these protections would not apply to health insurance sold through an AHP that kind of meets this new standard of being a large group under ERISA. They could also charge higher rates beyond those permissible under the ACA that apply to the individual and small group market based on factors such as age and gender and occupation and group size, so long as the association does not use health status of member groups to determine eligibility, premiums, and benefits. Unfortunately, the proposed regulation adds some confusion on the continued scope of state authority over AHPs. Currently, state authority over AHPs is quite broad. Basically, it allows states to regulate an AHP as they would any other insurer. So how did this come to be? In 1983, Congress amended ERISA to clarify that states have broad authority to regulate MIWAs, of which AHPs are a type. Congress did so in direct response to widespread fraud and insolvency of these types of arrangements. It was understood by Congress that in order to protect consumers, it was critical to remove any ambiguity over state authority over AHPs. Because of this broad authority, many states already are pretty well positioned to limit the potential risks, such as fraud and insolvency and market segmentation associated with a significantly expanded AHP market. For example, states have set standards to make sure that AHPs are financially solvent and capable of paying claims. By subjecting AHPs to market conduct and financial examinations, states can identify early signs of financial problems and take corrective actions such as ceasing new enrollment or initiating review as needed. On to the next slide, please. Proponents of AHPs suggest that these types of arrangements will offer lower premiums to employers, primarily through increased bargaining power and fewer regulatory requirements. This appears to be the intent behind the Trump administration's executive order to consider regulating an expanded access to AHPs. Next slide, please. It just seems important to point out that since the 1990s, congressional proposals to create federally certified association health plans have been opposed by a broad spectrum of stakeholders, including the NAIC. Opponents point out to this a history of association health plans that is basically rife with insolvency, fraud, loss of consumer protections, and market segmentation. When we just look at market segmentation, AHPs have in the past flourished by segmented the health insurance markets, which the proposed regulation helps spur by creating an uneven playing field between AHPs and the individual and small group markets. For example, under the proposed regs, AHPs could design plans unattractive to consumers with prior medical history, siphoning off healthy risk and leading to adverse selection and ultimately higher premiums for individuals and employers buying plans in the traditional insured market. The proposed regulation could be problematic for both the individual market and the small group market, which already faces the challenge of market segmentation from increased self-funding arrangements available to small employer purchasers. And then finally, if we can just go to the last slide, and this is really thinking about some of the state options to address AHPs. Of course, pending the final reg by the feds. And I think that the primary question is to what extent will states be able to regulate AHPs without being kind of inconsistent with this new federal AHP framework. I think it's fair to say if there's limited state authority, that there'll be an increased risk of fraud and insolvency and market segmentation. But assume that the state authority is maintained, states will still have a number of decisions to make, and how they approach it. These AHPs will depend on how they want to handle these possible risks and potentially the segmentation of their current insured markets. The first thing is, it's the slide. Unfortunately, I think the first question that states will ask is how will they claim jurisdiction over policies that are kind of set up in one state and then sold in another state. This proposed reg suggests that that you'll be able to set up an association in state A and then quickly kind of sell it nationally in other states. And so if a state is not legally set up so that they can claim jurisdiction over these out-of-state trusts, that could be initially problematic. So the first step is can a state claim jurisdiction over the policies that are just sold to their state residents when they're set up in another state. The second part is leveling the playing field. They can require compliance with some or all the individual and small group market rules. They could restrict AHPs. California doesn't allow new MIWAs, which are AHPs are a form of, and so only a handful remain. They could limit if they're concerned about the individual market. They could limit membership to their association market just to small businesses of the traditional definition, 2 to 50. So they'd have to be employers with at least one employee, kind of cutting off the self-employed and sole proprietors, which would traditionally buy in the individual market. They could also look at ways to reduce the effect of market segmentation from this proposed reg. They could assess AHPs. Maybe that some of that money could be invested into reinsurance programs to bolster the insured markets will fill the effect. At the end of the day, the impact of the Trump administration's AHP proposal on the individual market and small group market really remains uncertain. Will likely depend on the leeway AHPs are afforded in marketing to the self-employed and using members' health status to determining eligibility, premiums, benefits. Perhaps most critically, however, is the proposal's effect will depend on whether states will continue to have broad authority to regulate AHPs and whether they take the steps that they to kind of level the playing field between these new arrangements and their insured markets. So let me just hold off there and hand it back to Trish.
Great. Thanks, Kevin. Could you speak a little bit more about the what a state can do to assert jurisdiction over AHPs if they don't currently have a MIWA law? If they can't, what does that mean?
Yeah, so we looked at this pre-ACA, and about half the states, told us that a plan was set up in another state and sold to residents of their state, that they actually didn't have jurisdiction over those policies. It's a statutory authority that they have to have in place. And so what I always found surprising is sometimes you would look at two states that look like they had the same language, but one state's claimed jurisdictions over these out-of-state trusts or these national associations, and others didn't. So it's a statutory interpretation of their law.
Great. This is really putting you on the spot. Can you think of a state as an example that does have the broad reach over out-of-state plans?
Yeah, I mean, California is always a good example. So California jurisdiction over out-of-state trust, and then they, as far as I understand, and then they also have a regulatory framework that doesn't allow the existence of new self-funded MEWAs or AHPs. And then even for MEWAs or HPs that are using insured products, they kind of embrace the pass-through approach, meaning they have to come to compliance with the individual and small group market rules. And as a result, California has very few of these arrangements. And this was all kind of in response. I think it took place in the 90s when they put down this framework, and it was in response to insolvencies in the AHP market.
Yep. Great. Thank you. Let us move on. I'm sensitive to time. Remind our listeners that if you have a question, go to the chat box on your screen and add your question. Let me move on now to Joanne Volk, again from the Center for Health Insurance Reform at Georgetown, to talk with us about healthcare sharing ministries. Joanne.
Back at the top. Okay. Well, so they have been around a long time for people who, in certain religious communities, who object to secular insurance and instead opted to share each other's healthcare claims directly. They vary from one ministry to the next, but there are some common features across most ministries. They limit membership to those who share a set of religious beliefs, sometimes strictly so that you might need to demonstrate regular church attendance and have your pastor sign something for you. But others don't have a test at all for religious or ethical beliefs. Members make a defined monthly contribution that's typically called a share. We're still coming through okay?
Okay. Yep, you're fine.
Okay, and those shares may vary based on the level of coverage that an individual purchases, their age, and in some cases, health indicators. And the members submit their claims for sharing, and if they are deemed eligible so that they fall within the definition of what can be shared, they will be offset by other members' monthly shares. There's some exceptions for what can be shared, generally anything that's considered in conflict with the religious test for members, and that might include illnesses related to tobacco use or excessive alcohol use, pregnancy outside of marriage, but also generally anything related to a pre-existing condition. Other typical exclusions are for routine care, or including preventive services, mental health services, prescription drugs beyond a very limited set of time, so not maintenance drugs for a chronic condition, and then treatment for developmental delays for children. Next slide. The ACA recognized their role for certain religious communities by granting members from the application of the individual mandate, and has a specific definition that importantly says that the ministries have been in existence since 1999. Members must share a common set of ethical or religious beliefs and must conduct an annual audit that is made publicly available. You can find the definition at the citation included on your slide. But that exemption from the individual mandate does not impede state authority to regulate healthcare sharing ministries if they so choose.
7214 Southwest.
At this point, 30 states have safe harbors for healthcare sharing ministries, meaning that they are specifically exempt from insurance regulation. Some typical features of those safe harbors are that they provide their members with a monthly statement of member payment requests, contributions, a written notice that the sharing ministry is not insurance nor a guarantee of payment for claims submitted, and then some will also require an annual audit to be publicly available, as the ACA exemption does. Next slide. Healthcare sharing ministry enrollment has reportedly grown substantially since enactment of the ACA, from fewer than 200,000 before enactment to more than 1 million today. But that is by the reports from the trade group representing the 3 largest ministries, the Alliance for Healthcare Sharing Ministries. It is difficult to get any independent data on membership. And the audits, unfortunately, that are required by the ACA in some states only include financial information, not membership information. So it's difficult to know precisely how many members there are. But looking ahead, it seems that while the ACA mandate exemption is often constantly in the healthcare sharing ministry marketing materials, so that members knew that they wouldn't be subject to the penalty, the main driver appears to be now affordability. Much like these other options we've talked about today, they have a lower upfront cost and seem to be a reasonable alternative to ACA-compliant coverage, particularly for those that don't qualify for subsidies. Many are using features that closely resemble insurance. It's moved well beyond publishing a list of names of those who need help paying bills and getting contributions from other members as they are able to contribute. Some are using advertising during open enrollment to grab members. Others use paid brokers to enroll new members. Some refer to a provider network and might even charge people more if they don't use those providers and suggest they carry the membership card and present it to a provider as evidence of membership and help for paying claims. And then they exclude pre-existing conditions from coverage with various degrees of look-back, up to 5 years in some cases, and then limited coverage for those pre-existing conditions once enrolled. Next slide. With these features similar to insurance, there's a real chance of consumer confusion. Both the marketing during open enrollment and using brokers, as well as the plan designs, may mislead consumers into thinking they're getting insurance, despite the notices that are required by state safe harbors saying that they are not insurance or guarantee of payment. For example, use of provider networks, and even the very idea of a benefit design, that there's a specific set of rules that governs what can be shared and what cannot, might confuse consumers into thinking they're getting something more akin to insurance than health sharing ministry that may not pay claims if the shares are not sufficient in any given month. And in some cases, features may cross the line into something more akin to operating as an insurer. For example, if they're facilitating payments rather than just publishing needs and shares available, or requiring a specific defined contribution, not just as you can provide based on your ability to help offset costs. And then depending on actual membership and future growth, they might contribute to selection against the regulated market, as we've heard with these other options today. It's hard to know without hard data about how many individuals are enrolling in these plans, but it has the potential, especially when combined with other options, to pull healthy individuals from the ACA marketplaces and the ACA-regulated individual market. And then it's important to note that while these have traditionally been thought about as a coverage option for individuals, some now, with newer models, are specifically targeting small employers for coverage, in some cases pairing them with MUC plans to then supplement that coverage. Next slide. I'll go briefly through some state options to address healthcare sharing ministries. All states, regardless of their safe harbor status, do have some options, although admittedly they may be difficult to employ for various reasons. Importantly, I would suggest establishing a reporting requirement to collect data and understand growth and potential impact on market. It's just hard to know who's potentially affected and where you might worry about consumer confusion or the potential for selection and the impact on the individual market if you don't know how many people are enrolling in these healthcare sharing ministries. Second, states could issue consumer alerts educating consumers on the limits of healthcare sharing ministries. Some have done that in the past, but might suggest that particularly during open enrollment, when some step up their marketing, would be a good time to target consumer education. Then also in states with a safe harbor, one clear-cut option is to monitor healthcare sharing ministries for compliance compliance with the definition of healthcare sharing ministries. If they fall outside that definition, for example, by using brokers in some cases or facilitating payments between members instead of just publishing needs, or failure to apply a religious test for membership, if they fall outside the definition for the safe harbor, they then, of course, fall outside the safe harbor. And then finally, taking action against those that operate illegally as insurers. And I'll leave it there in case there are any questions.
Great, Joanne. And there are a couple that fall in the same sort of bucket. What exactly are these ministries? Are there any non-Christian ministries? Does the IRS post a list of permitted ministries? The definitional issues are concerning.
Yeah, so of course with the mandate going away in 2019, it's less important to know who made the list for those ministries whose members were exempt. It's our understanding that there is no publicly available list of which members or healthcare sharing ministries met that definition in the ACA, and so their members were exempt from the mandate. Some ministries have made available on their websites the actual letter that they got from CSIO, but there's no comprehensive list of which ministries met that definition. And some newer ministries, we understand from press accounts, have joined with those that were in existence prior to 1999 in order to have their members also gain the exemption from the individual mandate.
And are any of them non-Christian, do you know?
Well, there's one, and there may be more, but we looked at a number of them here that don't apply a test at all. But those that are generally Christian and not other religions.
Okay. And how is it legal for an insurance broker to sell ministry coverage, given that it isn't really insurance? Yeah,
there's different responses we've heard on that. Some actually are concerned that it doesn't comply with their E&O insurance. Some will feel that it's not within their duties to represent these policies as a legitimate option for the clients that come to them. But others there's a ministry that doesn't call them broker commissions. They call them, I think it's affiliate. They call them affiliates. They sort of rename them. So it is difficult. But if there would be any area to target for state attention, I think it would be the use of brokers. Certainly not all of them use brokers. Some find it's inconsistent with their goal of transparency to use brokers to sell memberships. But you might regard those that use brokers to be perhaps the most concerning portion of this group of ministries, because if they're operating or marketing during open enrollment and using brokers to reach people, I think you really drive up a possibility for consumer confusion.
Yeah. And I would remind viewers that add your questions to the chat box. As long as we're on the topic of brokers, let me go back to Danya. You talked about when talking about the short-term limited duration plans, you talked about stacking, and that some states were making sure they limited to 3 to 6 months to prevent stacking. But we've heard cases where brokers are using different issuers and stacking. So you buy one 3-month plan from issuer X, you buy another one from issuer Y, and you are able to get a year's worth of coverage from 3 or 4 different issuers. Is there a way to regulate that?
So there is a way to regulate that, and I would really recommend for that to look at Colorado's law, which does allow people to be covered for 12 months, but the durations can be changed. And what Colorado's law says is that an issuer cannot sell a short-term policy to an individual who has already been enrolled in more than one plan within that 12-month period. So basically it's limiting each individual to 2 plans in a 12-month period. You could also limit to 1 or to 6 months, something like that. And then that law also actually requires a question on the questionnaire: have you been enrolled in more than one plan within that period? And if the answer is yes, they cannot be offered that plan. That doesn't prevent, of course, against someone who misrepresents if the insurer does not find out, but it provides some limits and obviously would prohibit a broker from knowingly enroll someone in multiple plans if a state had a 3-month limit and allowed someone to be enrolled in only 1 or 2 plans within a 12-month period. That's really the only way to get around the stacking into multiple different issuers is to apply that to the individual. And then if you do apply a limit to an individual, you have to somehow include it in the application for the issuer to find out the information, or the insurer will never know.
Great. Let me flip back. We're getting more questions about the ministries. Is it your sense, Joanne, that the ministries have peaked in the enrollment since there's no longer a mandate and they were used as an exemption, or do you anticipate that enrollment will continue to grow?
It seems the driver now is the affordability issue and not, while, as I said, many ministries would point to the, even including the citation I have on the slide there for the ACA exemption as sort of a assurance that you can sign up for it without being subject to the penalty. It seems that it's the affordability issue now, that it's the individuals who find that they can't afford ACA plans without a subsidy that are the main target.
So we have another question about what do the ministries do with their built-up surpluses, and do we even know that they have built-up surpluses?
No. I mean, the audits, include financial data, and you can see the growth in what they're taking in and what they're sending out, but we don't really have information about surpluses. And if anything, they'll say that if any given month the shares don't cover the needs, then people's coverage will be prorated. So, for example, if you get 90% of the shares that month, 90% of shares, then you would only cover 90% of what people would expect to be covered in another month. But they say that they have not had to do that very often, the ones that we've talked to.
Okay.
And some do, on that point, some also collect an administrative fee. It's not just the share moving around between members. Some will take, for example, one monthly share out of each individual's annual membership for administrative costs, or another ministry takes, I think it's like 9.9% off each month for administrative costs. So some specifically make clear that they are going to take some money for the ministry itself to administer these.
Okay, good. So I'm not sure who wants to answer this, maybe Kevin, but there's a couple of questions that I would characterize as the elephant in the room, which is given the unaffordability in the individual market in the current ACA environment that will only be exacerbated by all of this, but given that issue, isn't it better to have these short-term plans, these association plans, these lower-cost plans than uninsured? Or maybe more affirmatively, what can a state do to compete against these alternative plans?
It's a great question, and I think one thing I do know is, by segmenting the market, it doesn't lead to better premiums for anyone except for people who are going to get less benefits for their coverage. So, for example, yes, people will, at the cost of premiums rising up for comprehensive coverage further, people will be offered less expensive short-term policies, but these policies don't necessarily cover pharmaceutical coverage, maternity, mental health. They often have annual limits, lifetime limits. And if you get sick, when you try to renew, you don't have, you're not going to pass underwriting for the second time around. So, for policymakers, I think it's this balancing act that we talked about before. How do you improve the stability of the market for everybody to have access to comprehensive health insurance, while not quick fix of allowing people to have access to a cheaper policy that doesn't necessarily cover their needs when they get sick. So, but
it sounds like we're back to the future. This sounds like what the individual market looked like before.
For 10 years, I'm sure many people on the call right today, they're very familiar with the individual market pre-ACA. The short-term policy market, to me, is starting to emerge as a parallel market, individual market, before the Affordable Care Act, but in many ways, it's less regulated because because
Yeah.
states, we've gone through this process of trying to figure out what is the regulatory framework under which states currently regulate this short-term market, and quite frankly, it's still evolving in many states. But there isn't a body of law that applies to these these short-term policies.
Mm-hmm.
So mandates that a state, had wanted to apply to their individual coverage arrangements don't necessarily apply to short-term policies. There's no internal appeal rights. There's no external appeal rights necessarily. There's no rating restrictions. There's no renewability rules. This is a totally, in many states, a totally unregulated market, and which should at least raise some level of discussion in states about what they're allowing consumers to get for that cheaper policy. In some cases, it may prove to be not much.
So it raises a devil's advocate question, flipping back to the potential challenges of association health plans. You said that previously there were real serious fraud and abuse problems with AHPs. How great was that? And that was when states could regulate AHPs. So why was there so much fraud and abuse? And why weren't states able to nip it in the bud when they had regulatory oversight?
Yeah, no, that's a great question. And states that were active in this market were effective, right? In doing so, in states that chose not to be aggressive in their regulation of health insurance sold through associations, or kind of created regulatory incentives, it proved to be problematic. I think much of it was actually, often when we looked at this pre-ACA, scam research, and I'm happy to send out to this audience a work that was completed by the Commonwealth Fund, or for the Commonwealth Fund on MIWA scams. It was often these national associations, where you citist in one state and sold in another. Mm-hmm. And there was continued ambiguity under federal and state law about who actually could regulate, and that was problematic, especially in states when you had a combination of states that kind of lightly regulated versus closely regulated. So I think going forward, what we really need to do in the coming weeks, and when this final reg comes out, is if states, if their regulatory authority is maintained, we're entering kind of a new phase, because now you almost have you have a situation where you, in very short order, an association can kind of create an AHP, which can go from not existing to being sold nationally to millions of people very, very quickly, with very little federal oversight. And some states will step up and regulate closely and set up systems to monitor closely what's being marketed to their members. And others won't. But again, I think if states are given the regulatory authority to maintain jurisdiction over MIWAs and regulate them, then we're entering a different phase, and it almost kind of takes almost like a rethink, even maybe learning the lessons from pre-ACA, but applying to an environment that will likely see many, many more HPs.
Great, thank you. And if you send us that link, Kevin, we will everybody add it to the slide so that you'll have it in easy access to it.
Yeah, I think there's two papers that you might want to look at. There's one on fraud, AHPs using as a vehicle for fraud, and then there's another one on insolvencies. And when you think about AHPs insolvencies, it's important for states to realize that it's not just consumers holding the bag, it's also hospitals and providers. And it's pretty well documented that if you have an association or an AHP that goes into insolvency, that there's a lot of loss at the provider level and then at the consumer level.
We have two more questions. And I know we lost some time, so let's go through these last two and then close out. One, Kevin, on this theme, what do we think might be the future of the Farm Bureau plans? Obviously Tennessee has been operating theirs for almost half a century. Iowa, what do you think might happen?
Yeah, I mean, if you look at the Tennessee market and the Iowa market, these are extremely fragile markets. I know Iowa has just, passed legislation on this front, but it's extraordinary to me that a state would basically carve out health insurance coverage and not regulate it under their state law. I mean, essentially that's what has happened in Tennessee and what will happen in Iowa. So that's the first thing that is quite surprising to me. And then second of all, if you look at the Tennessee market, there were they had a very small risk pool for comprehensive health insurance, and that was in part because their Farm Bureau plan was, which was completely underwritten and totally exempt from state law, held a fairly sizable healthy risk. And as a result, it was a state that, of course, had problems attracting issuers, and saw premiums increase for the segmented market. So, yeah. I mean, I think states that look towards exempting associations or creating an exemption for Farm Bureau plans like Tennessee and Iowa really need to look at the long-term consequences of doing that and the effect on premiums and plan and competition, for their insured market as a result of making that decision.
Great, thank you. And last but not least, one nitty-gritty but important question, Joanne, on Ministries. Do Ministries require their members to pay their share? Are there exemptions for financial hardship?
Good question. Some might have individual policies. I'm not aware of a blanket policy. I think some might have some policies that if you can make an appeal based, you can avoid it, but many say you lose membership if you don't pay your monthly share.
Okay. With that, we will post these slides. We will post the webinar for future reference for everybody. I want to thank Kevin Lucia, Dania Palanker, Joanne Volk from the Center for Health Insurance Reforms at Georgetown for a great seminar, and thank all of you. We very much encourage you, please it takes 1 minute to complete our short survey, but it makes these webinars all the better when we hear from you. So thanks to everybody who attended, and please do fill out your short survey. On behalf of the National Academy for State Health Policy and our colleagues at the Center for Health Insurance Reform, thank you.